Hi, Joan. Joanne. I can't. Oh,
Hey
one
Mary,
second.
how are you doing?
Oh, now I can hear you. Um,
Mm,
what?
I was muted before. I'm sorry. I was like, oh shoot, I gotta unmute myself.
Oh,
Uh,
I don't know why.
hey, when I'm sharing this, what do you see? Do you see like just the one slide, or do you see everything? Because sometimes I end up
I see the
sharing.
one slide.
Wonderful, good. That's as it should be. Let's see.
I wonder
Yeah,
why
you can take it there.
my camera's not working good.
Yeah, yeah. I'm seeing like the side of a yeah.
It's weird. Hmm. I'm not sure.
Before, as well as Swan. I think you've seen them both. They'll be presenting our didactic day on anxiety. And Mary, if you could go ahead and hit record for us.
Okay, thank you so much for having us. So we're hoping you're going to come away from today feeling confident in identifying and diagnosing anxiety disorders in primary care, understanding what are the evidence-based treatment options, both medication and therapy, and then having some resources that you can provide to families. Next slide. So first of all, what is anxiety? Anxiety is a human emotion that we all experience, and there are three main components to anxiety. So there's the feeling piece of it, the physiological sensations that come along with anxiety. Think the fight, flight, or freeze response. As I'm giving this talk right now, I have a little bit of anxiety, so my heart might be going a bit faster. Then there's the cognitive component. So usually when we're feeling nervous about something, our mind is jumping ahead to what bad things might happen. And so I might be thinking, what if I make a mistake? And then the last piece is the behavioral piece. So anxiety is an uncomfortable feeling. It doesn't feel good to be anxious. And so as a general rule, we try to avoid situations that make us feel nervous or try to get out of them or escape from them as quickly as possible. And so this is, again, it's a feeling that we all experience, and at many times it can be really helpful and adaptive, but there are times that anxiety can become a problem. So when I'm talking to families about this, I'll often use this broken smoke detector or false alarm analogy. So I'll ask, have you ever experienced your smoke alarm going off when there was no fire? Maybe somebody burned the toast. And pretty much all families say, yes, absolutely, we have had that happen. And then I'll go on to explain, well, this is what's happening with anxiety sometimes. This alarm is going off. Your brain is sending all these signals to say that you're in danger, but it's all smoke and no fire. And this can lead to lots of problems. And so when I'm thinking about, is anxiety really like rising to the level of a disorder, I'll consider the 4 Ds. So I'll think about dysfunction. So is anxiety holding this child back from doing what they want to do or doing what they need to do socially with friends, at home with their family, academically? I'll also think about distress. Is anxiety causing significant distress? Again, it's an uncomfortable feeling to have, and so it can be really upsetting if this is happening a lot. I'll also think about duration. So it's really typical to have heightened anxiety around a transition point. So we're all thinking about and planning for a return to school next year. And so we would expect that a lot of children and teens are going to be having heightened anxiety that first week or even first month of going back to school. But if this anxiety is persisting, if it's going on for longer than 3 to 6 months, that suggests this isn't going to go away on its own. And then the last piece is to think about deviation from the developmental trajectory. So is this child experiencing more anxiety than we would expect given where they are in development? Next slide, please. So just some quick facts about anxiety disorders. This is the most common mental health problem to affect children and teens. I'm sure you hear about this all the time in your practice. 3 in 10 children will meet criteria for an anxiety disorder by the time they reach age 18. That's a lot. And then we also know that anxiety disorders often go overlooked. A lot of times this isn't identified. And at the same time, it can cause really significant impairment in academics, in social functioning, and with the family. So sometimes people will say, let's just watch and wait. Let's see, maybe this kid is going to grow out of it. And that's usually not what happens. So without treatment, anxiety disorders most often do persist into adulthood. And when they're left untreated, I think as we'll see with some of this case discussion later on, it can really lead to more problems over time. So it can lead to the development of other anxiety disorders, depression, substance use. So this really makes a great case for identifying and treating anxiety disorders early on. And that's why we're all here today, because primary care offers this beautiful setting to really be able to increase the identification and treatment of anxiety. Next slide, please. So on this slide, we have just some of the more common types of anxiety disorders, and I'll quickly go through sort of what are the cardinal features of these anxiety disorders. And the other thing that I want you to have in the back of your head is that with anxiety, comorbidity is the rule rather than the exception. So it's really common for children to meet criteria for more than one anxiety disorder, or to have sort of different flavors of this anxiety and just have generally elevated anxiety overall. So separation anxiety is more often seen with younger children, as you might imagine. And the key feature of separation anxiety is the child's fear that something bad is going to happen to them when they're separated from their parents, like they might be kidnapped, or fear that something bad is going to happen to their parents, like their parents might get into a car accident or might leave and never come back. And because of this fear of separation, you often see difficulties around going to school, separating at bedtime, staying with a babysitter, or someone who's not in the primary caregiver role. And we'll also often see physical symptoms that come along with anxiety. So the child might not be able to say that they're feeling nervous, but they're having belly aches or headaches when they're separating, or might even have nightmares about their parents getting hurt. Generalized anxiety is really characterized by worry. So that's when you're thinking generalized anxiety, think worry. Of course, we all worry, but for children who meet criteria for GAD, these worries are excessive, they're sticky, and they're hard to control. And they can be in lots of different areas. So some children will worry pretty exclusively in one area, maybe around school and grades and perfectionism. Other children might have kind of flavor of the day worries that change every week. So it might be worries about getting hurt or things they see on the news or family finances. It can really be about a bunch of different areas. And then the other part of GAD is that it's associated with one or more physical symptoms. So when worried, these children might have things like trouble sleeping, they might feel more tired, they might have muscle tension in their neck or arms or legs. Again, you see headaches, belly aches. I'm guessing you see that a lot in primary care. Irritability and trouble concentrating when worried. Social anxiety, we see this come on board more during the adolescent years when everybody in general is starting to care more about what their peers think of them. And the key feature of social anxiety is fear of negative evaluation, worries I'm going to do something stupid or dumb and people are going to laugh at me. And there are kind of two main buckets that social anxiety can fall into. So one is feeling nervous in performance situations. So with children, we might see feeling nervous or avoiding class participation, presentations, having a picture taken. And then the other main category is more unstructured social situations. So things like having a conversation, calling or texting somebody, going to a party. So you can have social anxiety in either or both of those bigger buckets. The next on the list here is panic disorder. So panic disorder is characterized by panic attacks. And at least one of these panic attacks has to happen out of the blue. So you can have panic attacks that come along with generalized anxiety if you're worrying about something, or that can come along with social anxiety if you're feeling nervous in a social situation. But with panic disorder, at least one of these happens out of the blue. You're not in a scary situation, you're not thinking scary thoughts, and then there's a lot of related distress and impairment that follows. And then the last one that we have on here is OCD. OCD is not technically in the anxiety disorder section anymore, but it's really similar, often co-occurring, and the treatment is similar as well. So OCD is characterized by intrusive thoughts. So for example, I might have an intrusive thought, my house is going to burn down. And then related compulsions or rituals that can take a really long time. that where the aim is to make that intrusive thought go away or to decrease the likelihood of that intrusive thought coming to fruition. So for example, in the case of my house burning down, I might spend an hour kind of unplugging all the plugs in my house before bedtime and making sure they're a certain distance away from the wall to prevent this feared outcome of the house burning down. And then this can, all of these anxiety disorders can look really different and present really differently across children and teens. Next slide. So Lauren is going to talk about
some of the questionnaires that I think are most helpful for helping to screen and track anxiety disorders are the SCARED, which is the Screen for Child Anxiety Related Disorders, and the GAD-7. I think that the SCARED is particularly useful in pediatric settings. It's validated in research for ages 8 to 18. There's both a parent and self-report, and it looks at a number of these different types of anxiety, which I think can be really helpful because I know it can be hard to remember to ask about questions about separation anxiety and social anxiety, general, all of these, where this kind of covers a lot of ground. The main downside is it's 41 items, so it is a little bit longer. I think it's often helpful to kind of give them to the parent and child and have them fill it out on their own time and bring it back. And then the GAD-7 is validated for 13 plus. This one's it's a self-report, so it'd be the teen filling it out. And this focuses particularly on generalized anxiety, but is much shorter to fill out. And both can be used for kind of getting a baseline and helping with diagnosis, as well as tracking response to treatment over time. And they're available at the CAP website linked there.
Okay, and there's some good news here. So once you've identified that anxiety is causing a problem, there are effective treatments. So the American Academy of Child and Adolescent Psychiatry guidelines says that both medication and treatment are part of the clinical guidelines. Next slide. So I'm going to talk a little bit more about cognitive behavioral therapy, which is the type of treatment that has the most evidence and support for treating anxiety disorders. And then Dr. Schumacher will talk more about the medication piece. So in CBT, there are skills that are taught that really address those three different aspects of anxiety that we were talking about at the beginning. So to target the physiological component, that activation in the fight or freeze system, therapists will often work with children and teens around relaxation and mindfulness strategies to really calm the body down. To target that cognitive piece where anxiety loves to convince us and overestimate the likelihood of bad outcomes and underestimate our ability to cope with those outcomes, therapy uses strategies like cognitive restructuring to identify more realistic and helpful thinking. And then the key ingredient of good, effective treatment for anxiety is doing something that's called exposure. So with anxiety disorders, the thing that really maintains it is avoiding whatever makes us feel nervous. And so gradual exposure is helping the child to gradually face their fears and practice doing those things that make them feel nervous. Next slide. So this is just more about exposure therapy. So we know that a lot of different things might cause anxiety, but avoidance is really what maintains it. So I'm feeling nervous, I avoid the situation. That's a great short-term strategy. I automatically feel better, but I don't learn how to handle that situation and I actually stay nervous in the future. And so exposure therapy really aims to stop this cycle, to help children and teens gradually practice facing and staying in those situations that make them feel nervous so that they increase their ability to cope. Next slide. And then on this slide, we have some suggestions about how parents can be involved. So parents can play a really key role in supporting their child to gradually face fears rather than to avoid anxiety-provoking situations. I think for the sake of time, I'm not going to really dive into this, but we have some resources that we'll be able to share at the end that you could also share with families and parents that give them some tips and suggestions on what they can do. Next slide.
So while for most kids dealing with anxiety, really the place to start is going to be with behavioral interventions, both kind of family self-guided ones and then potentially working with a therapist. There are situations where medication can be helpful. Some of the times to think about treating anxiety with medication is when there's been limited improvement with therapy, when the symptoms are particularly severe, when they're maybe trying to do therapy, but their anxiety is so intense that they're unable to tolerate doing even kind of simple low ladder exposures like Dr. Swan was discussing. And also if there's comorbid depression that would also require treatment. And I think something to keep in mind is while both CBT by itself and SSRI medication by itself is effective for treating anxiety compared to placebo, the combination of CBT and an SSRI is most effective. And then briefly, so in the next couple talks, you're going to be discussing depression, and then there's a whole echo on SSRIs, which we'll go into more detail. But the main ones we think about for anxiety are sertraline, fluoxetine, and escitalopram. While some of them are FDA approved for kids and teens for OCD and MDD, they don't have specific approval for things like generalized anxiety disorder or social anxiety disorder, but there is good data that they can be helpful with a number needed to treat of 3, so they can be pretty effective. Generally with all of these, you start at a low dose and work way up gradually, and tune into future echoes for more details. And then finally, in the handout, there's a much longer list of both online and book resources for families and kids. But I really recommend these. What to do when you worry too much is a children's workbook, essentially, that really goes through the steps of CBT at kind of a kid level. And books like Helping Your Anxious Child is geared towards parents and helping them. So I think these are a great option, especially for those kind of borderline kids where they're, you can see that they're anxious. They're coming in sometimes with stomach aches or headaches or having some worries about separating from parents, but are not impaired yet to the extent that they need therapy or medication. These books provide really helpful guidance for parents and kids about how, even on their own and with parent-family support, they can practice exposures and learn how to manage anxiety. And then those are our references.
You guys did such a great job of doing an efficient job of getting through this. So I think we might actually have a few minutes. If people have a few questions about this presentation, I just want to open it up. If there are 1 or 2 questions that people have that we might be able to address really quick before we move.
Make people feel a little bit more energetic, sometimes a little bit more restless. And this can be, I think this can be a good thing, in, especially when it's being used to treat kind of those more depressed kids with low energy, low motivation. That activation can be helpful. Sometimes with the really anxious kids, especially the ones that are somatically focused and really, a little bit of heart rate increase or restless feeling makes them feel more anxious, the activation can be a less good option for those kids.
Wonderful. We do have a couple of minutes and I see a couple more questions here. Maybe this is for Anna. Can you describe exposure therapy and how it's done?
Yeah, absolutely. So you start by the child and the family start by creating a fear ladder or an exposure hierarchy where you pick an area, whatever the fear situation is. So for example, if it's talking to new people, So you might start by having the child practice making eye contact with somebody that they don't know. That would be really low, potentially pretty low down on the hierarchy. Then you might have them practice calling a store or asking somebody for a stapler or something like that. So kind of have them practice like talking to new people in those situations. Then you might, at top of the hierarchy might be walking around on the sidewalk with your jacket turned inside out, singing Hamilton at the top of your lungs, like on purpose, doing something that feels really, really embarrassing. To have this experience of, you know, I was able to do it, I was able to handle it. After that, like answering a question in class is going to be a walk in the park. So you work with the child to kind of create this ladder, and then both in session, you practice doing exposures with them. Sometimes that's where people make a mistake. Maybe they don't do it in session, they just say, go ahead and do it on your own, but you really want to do it in session. And then you also will have them do practice between session where they're doing this. And it's a great way to involve parents too, to help them with reward systems, because it's hard to do exposures or brief challenges. And so with younger kids, you might do a point system with really tangible rewards. With older teens, they might be working towards some larger thing like driving lessons or something else that they're really excited about.
Okay. We'll include a separate handout on CBT providers based on our resource list later. That'll come out by email, so look for that. Last question is PTSD a form of anxiety? And maybe either Lauren or Anna, if you want to take that one.
This is a great question. So PTSD actually isn't in the part of the DSM that's talking about anxiety disorders. It's in its own separate section that's talking about trauma and stressor-related disorders. That being said, anxiety is a really big component of PTSD. And in terms of therapy, some of the therapies are similar. So you work with a child or a teen to learn strategies around emotion regulation, and then you might also have them work on what's called the trauma narrative in trauma-focused CBT, where they actually go back and write a narrative of what had happened so that they're able to have those memories be less distressing.
Wonderful, thank you so much. And yeah, I wanted to point out Lori's comment of just the important role general pediatricians play in preventing like emerging anxiety from getting worse and giving really specific timely guidance that can make a huge difference over the course of a child's life. So thank you so much, Anna and Lauren, for your great talk today and for answering these questions. And with that, let's go ahead and turn to our case. And I'm just going to briefly remind everybody that this is kind of the format